All right, welcome. Changing a couple things. All right, I'm going to get started. This will be recorded and be available on our YouTube channel. So if you haven't, you're not able to see this live, that's okay. I'm Dr. Jesse Morse. I am a sports medicine and regenerative medicine specialist here at the Osteopathic Center. This is our Miami office. As you can see here, this is our IV suite. You can kind of get an idea of what you would get if you were in our office getting an IV. This is not your regular IV clinic. So I wanted to start off this new lecture series talking about knee pain, talking about knee arthritis. Now, knee pain is very, 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 very common. And unfortunately, most people will have it at some point in their life. Whether it's younger because of an injury or a sport, or older because of arthritis or what I call wear and tear. Now, most of the time, unfortunately, these cause pain every day depending on how active you are. Some of the injuries that we suffer early in life end up causing issues later in life in terms of arthritis, in terms of immobility or decreased range of motion, chronic throbbing, aching kind of description of pain. Overall, arthritis is almost inevitable. I wouldn't say 100%, but it's very close. In my opinion, really, as we get older, start thinking 40, 50s plus. Can you get it in your 30s? Yes. 20s, possible, but very rare. Usually it's at a minimum 30s, and that's with a bad injury earlier in life, or starting in your 40s and 50s. So arthritis itself is very complicated. It is not easy, straightforward, and there's multiple different pathways to it. There's multiple different causes to it. There's a genetic component to it that we really can't control and don't have any effect on per se. But there are things that we can change, and that's kind of what I want to talk about today. The rate limiting factor for arthritis is that every single thing that we do in terms of walking, sitting, pushing, pulling, getting out of bed, getting in a car, driving, walking upstairs, walking across your living room, all require your knees. You don't have a choice. So you are going to have some wear and tear injury on your knees. Some people have it a lot worse than others. Most people think that, unfortunately, a lot of people believe that give me one sec. I had a question and it sounds like it's a concern. All right. Sounds like the audio should be coming in fine. Just double checking that. All right. So most people think that they walk like this, but in actuality, most people walk like this. So what I mean by that is we have a lot more wear and tear on the inner aspect of our knees. So if I were to bring up my knee, the inside of my knee gets more wear than the outside. That's about 70-ish% of people. So if you think of it as your car is out of alignment and the inside, or the part of the tire that's closer to the engine, gets more wear than the outside. So what happens? As you drive those tires more, which is a beautiful analogy for arthritis, you're going to have a significant more amount of decrease in the tire or cartilage in that part of the knee. If you putting your weight down and 80-70% of the weight is only on one part of the knee, what part of the knee is going to get the biggest wear and start to fail the most? Makes sense, right? So if we can correct some of that, or if you happen to be one of the people that are blessed with actually walking like this, which does not really happen that often, maybe 10%, 15%, then you get lucky because you have an even wear pattern in your knee, within the cartilage in your knee. What is the easiest way to see if you do this? Look at the bottom of your shoes that you've worn more than 10 times. If you see that your heel is kind of being cut on one side as opposed to the other, that tells you that you don't walk perfectly square, and as a result, you're going to have wear and tear. Some of this is from the hip, some of this is from the knee. But either way, it does play a role. We usually don't worry about the ankle. And as a result, you're going to have significant more issues on the part of the knee that gets the biggest wear. So I'm going to show you a beautiful model that it is very helpful to explain what's going on here and exactly what's going on with arthritis and how we can help it. So I'm a visual person, not everyone is, but I feel like this one really helps to translate exactly what's going on with arthritis. So we start here on this side. For simplification purposes, they remove the kneecap, which would be basically floating over the top, so that you can actually see the joint. The knee has 3 compartments. What we call the patellofemoral joint, which is the kneecap and underneath the kneecap. We have the medial joint, the inner aspect of the knee, that's on the inside. And then the outside or lateral compartment, which is where this small bone is. So you can see it kind of over here. You can have arthritis in all 3 compartments. That's what we call tricompartmental arthritis, and that's the worst one. You can have it only on 1. You can have it on 2. Most people are usually going to have it on the medial aspect because of the way that they walk, like I just mentioned. You can have it on the lateral, not super common. And a lot of people will have it what we call patellofemoral, or underneath the kneecap. And I'll tell you about that in a minute. So if we look at the knee, there's 2 types of cartilage in the knee. One, the meniscus that most people have heard about. That's like the shocks for your knee or the shocks for your car. There's 2 semicircular rings. They're one on the inside and one on the outside. They basically kiss in the middle, but they're 2 separate pieces. They sit in the front and they insert kind of in the back of the knee. These are responsible for any squatting motions, any walking on uneven surfaces, and any twisting is all meniscus. This is what it's used for. The other important thing is it provides lubrication to the joint, but it also allows the bones from preventing of smashing into one another. So when that happens, you're going to obviously have a lot more wear and tear at the bone than if you had a cushion that was protecting that bone. The other part of the cartilage that most people don't really appreciate is this blue part on the model. That's what we call articular cartilage. Think of the articular cartilage as almost like a door frame, and now think of the shellac on the door protecting that wood. That's what the articular cartilage does for the bone. This is what causes us to develop arthritis. As the articular cartilage starts to wear down, the amount of osteoarthritis starts to build up. It's indirectly correlated. So the issue is when we start off as young people like this, but then you start developing injuries, compensation patterns, weight plays a role, we'll talk about that in a minute, and multiple other factors, and you gradually start deteriorating the joint. Now, because we're bipedal and upright walkers, we don't really have a choice. We have to use our knees. But if we can keep it close to normal as possible for as long as possible, we can ideally prevent the dreaded severe arthritis and usual knee replacement. So if we look here, you can see that you can start to see the red underneath this kneecap, where the kneecap would be. And this is the medial or inside part of the knee, because that's where I said it usually happens the most. That you're starting to see the bone itself be exposed, because the wear and tear underneath this kneecap starts to wear down, and you start to decrease the amount of articular cartilage, which indirectly causes wear and tear to the joint, which then starts to expose the bone. This starts to change the chemistry, or the different types of fluids within the joint, which become inflammatory, and they start to have a lot of pain and throbbing, aching, and stiffness. As that starts to develop worsening, you start to feel it more and more. Some people feel it even if there's not a whole lot of damage to the joint. Minimal damage, they may feel a lot of pain. And then some people, the lucky ones, are the opposite. They don't really have pain until they're like here. And it's like, how is that possible? I don't know if there's an explanation for it, but it's fascinating, and it's for the people that feel it already down here, it's unfortunate. But my goal with any of my patients is to prevent progression. Once you get here, it's very, very, very challenging to do anything in going backwards. But if you're here and you do the right stuff, you eat the right foods, you exercise, you take the right supplements, you maintain an appropriate weight, you can prevent progression. And if you prevent progression, you can prevent severe knee pain, severe knee arthritis, and eventual knee replacement for most people. So, as I say, and when I talk about concussions or anything like that, you can always replace your knee. You might not want to, but you can. But you can't replace your brain. That's the benefit of a joint. We can pretty much replace anything now. We can replace the big toe. We can replace the thumb, the elbow, the shoulder, the hip, the knee. I mean, you literally can pretty much replace anything. It's never as good as the original one. They're good, but they're not perfect. So ideally, you keep yours as long as you can. We have very high level runners that have had bilateral, both knee replacements, and they're still running. You can do it. It's just a lot harder, and you'll have some limitations. So it's not the end of the world, but ideally, if you can keep your knees as long as as long as they're strong and healthy, and prevent the progression, that's kind of the goal. So one of the biggest parts of this is maintaining your weight. Okay, healthy weight has kind of gone by the wayside in the United States. And there's a myriad of factors as to why that's happened. I won't really get into that part of it. That may be a separate discussion for a separate day. But one thing that's important to know is for every additional pound on the abdomen over what you're supposed to be, is 4 pounds on the knee. 4-to-1 ratio. That's just normal standing. Whenever you squat, the amount of weight or pressure on your knee increases 7-fold, 700%. So if you are 10 pounds overweight, now we're thinking we're basically 40 pounds extra on the knee, and then you're increasing that by 7, that's a huge jump. So one of my previous mentors is a very high-level orthopedic surgeon that specializes in knee replacements. And I remember I used to see a lot of his patients when he was out of town, or just, I would see him as follow-up. And it would always come up, he would see them, they were like, yes, I have bad knee pain, I expect it to be arthritis. And he would evaluate them, he'd say, yeah, you have some arthritis, but you're 50 pounds overweight or 100 pounds overweight. Before we do surgery, I want you to lose X number of pounds in X number of months or whatever. And a lot of the times I would happen to see them as follow-up. More often than not, the people that lost the weight didn't have the pain anymore. It wasn't because they didn't have arthritis. Trust me, it's still there. But they didn't feel it because they weren't carrying an extra 50, 100, 200 pounds of weight on their knee with every step. Do yourself a favor, prevent the progression of arthritis by maintaining a healthy weight. Injuries are also a big part of arthritis. If you tear your meniscus, which feels like you're getting stabbed in the knee with every certain movement, twisting, getting in and out of a car, going up and down stairs, grabbing something low from a shelf, these are all meniscal tear motions. Think of that as removing some of that cushion from the knee. So think we have 4 tires on a car and one shock on each tire. If you removed one of those shocks and still expected it to function, which is not realistic, it's not there, that's what happens in a bad meniscal tear in a certain part of the knee. So you're expecting the meniscus to perform its job, yet it's not there to perform its job. So the goal would be to prevent smashing of the bones, but also provide a cushion and nutritionally support the joint. The meniscus is vital. If we didn't have meniscus in our knee, we would all have severe arthritis by our mid-20s. It would be awful. And when some of the pro athletes, tear their meniscus and then they get it pulled out, or they have they tear their ACL, they get some of it pulled out so they can get back on the field faster. They end up paying the price several years later because they end up getting bad arthritis and the knee just doesn't want to cooperate like it used to. And that's, if you're a football fan, my suspicion is that's what happened to Todd Gurley. So this happens to regular people in addition to famous and very high level elite athletic people. So keeping the preservation of the meniscus is very important. You ideally want to keep in there as much as you can because that's going to continue to provide lubrication and continue to keep that articular cartilage healthy and safe, and as a result prevent progression and damage. I'm going to speed up now. We're going to do a couple other things. As you start to see, you'll see more and more wear and tear. This is severe or grade 3, depending on which scale you're talking about, for arthritis. So one of the things that's hard to appreciate is that I want you to realize how many different ways the arthritis affects the joint. Okay, so look at it this way. I'm going to bring this close to the mic, to the camera so that you can actually appreciate it. See how this joint is nice and smooth. Okay, see the edges? This is normal. This is a normal joint. When we get arthritis, our body tries to fix it with little pieces of calcium called osteophytes or bone spurs. What happens? See how crazy and jagged this bone is? Again, look at normal. See how smooth it is? Look how crazy this is. Okay? This is what happens. So we literally lose range of motion because of extra bone that has developed as the body's way of trying to help. It obviously doesn't help. It causes more issues. So prevent bone spur osteophyte formation by being weight conscious, by preventing injuries, by treating injuries when they're ready. And one of the other things that has shown some benefit is something called glucosamine chondroitin. Old school med. The data is okay, it's not amazing, but it's better than really anything we have that's oral and that's safe. And basically what it does is it helps to lubricate the cartilage. There's a couple famous versions and brands. The only one that has documented proof of exactly what it says it has in it is the Osteobioflex, and that's just not a promotion for them. This is just to say that that's the only brand that we've been able to prove that actually it has what it says it has in it. So that's something I personally take for what it's worth. Just if, adding a little bit of extra benefit where I can. It's not going to hurt. Okay, the other things that I wanted to discuss. Not only maintaining healthy weight and preventing injuries, but also staying active. Your body wants to be used. I almost think of it as like the Tin Man. If you sit there and you lay down and you don't do anything, you're going to rust. The joints want to be used, but unfortunately they do have, they can only handle so much. So there's a happy medium. But staying healthy, being active several days a week, whether it's walking, running, biking, swimming, using the weights at the gym, whatever you decide to do, yoga, all of these things stimulate bone healing, bone growth, and keep maintaining a healthy weight, and also help maintain good joints. When they do that, you're going to prevent this progression. What are other things that we can do if we already have arthritis? That's where we start talking about injections, which is my personal specialty. So you have your traditional steroid injection. What does that do? It basically tricks the brain into thinking there is no more pain. It might decrease inflammation a little bit, but it doesn't solve anything. It actually can decrease, it can decrease some of the cartilage in the joint, and it ends up being counterproductive. It doesn't cause any nutritional support to the joint, and ends up basically helping for a couple weeks to a couple months if you're lucky, and then you need another one. The problem is your body has already kind of figured out how to get rid of it, and now it needs more or lasts less time. You're basically kicking the can down the road, so to speak. You are band-aiding an injury until you finally accept that it's a bad injury and you need surgery to fix it or replace your knee. What other options are there? In traditional medicine, there are the viscosupplementation or gel injections. There's a bunch of different brands. They range anywhere from 1 super shot every 6 months, or depending on how long it lasts, or 3 to 5 shots. It just really depends. That is a glucosamine, basically a hyaluronic acid based substance that helps to provide nutrition to the joint. Do they work? Yes. Do they help progression? Maybe. Are they covered by insurance? Yes. But in general, they're helpful, but they are not really going to prevent progression. They're just helping you with symptoms and maybe a little bit of nutritional support for the joint. What I do here at the Osteopathic Center is what we call regenerative medicine. I am one of the specialists that actually, my goal is to not only improve and heal the tissue as much as we can, but prevent progression. I want to improve strength. I want to improve the different types of movements and correct instabilities at the same time as preventing progression of arthritis and injury, which indirectly can cause worsening arthritis. So there's a couple different options. I won't get super complicated with this, but PRP is probably the most common. That's platelet-rich plasma. That's where we take blood out of your arm, spin it down, get the super potent, rich, thick layer, and then inject that directly into the knee and in the surrounding musculature of the knee. That helps to correct some of the imbalances, provides nutritional support, and can do some healing for the arthritis. It's not the best stuff we use, but it does a pretty good job, especially if you're quote-unquote tightening the knee. A lot of injuries in the body are about instability, specifically orthopedics. So think of you driving your car and your lug nuts on your tire are a little bit loose. It's going to be doing this when it should be just going. That's essentially what happens to our ligaments that are controlling the knee, the hip, whatever joint we're talking about. So if you can tighten up those ligaments, you're going to decrease that instability, which indirectly is going to prevent progression of said injury. So that's basically what a lot of the times we're doing here. But you have to exactly inject each single ligament at either the base, the middle, or the insertion to strengthen it up so that it doesn't have as much play as it should or as it currently does. Sometimes you need to do it multiple times because they're really banged up. The next level would be something called bone marrow, which you've probably heard of before. That's where we take bone marrow out of the hip and we re-inject it right into the different parts of the knee or whatever joint we're talking about. Inflammatory, but very effective, super potent, and can significantly help with arthritis. We've had very good results with that. There's a couple levels after that that I won't really discuss here, but in general, they are even more potent and less inflammatory and very effective for not only arthritis, but other injuries. A lot of our professional athletes use these higher levels of regenerative medicine products. If you're interested, please contact us here at the Osteopathic Center, and I will happily discuss these for you and with you. In general, keeping a healthy weight, making sure that you don't have any injuries that are not being corrected. So sometimes you need to get evaluated by a physical therapist and make sure that things are being properly addressed. Taking supplements that keep you healthy and decrease the amount of inflammation in the body and in the joint as much as you can. Turmeric is another favorite of mine. Fish oil is another one that's a good quality at least. And you can be proactive as opposed to reactive and actually inject things in and around the joint that can significantly help strengthen up the area so it doesn't have as much play and indirectly prevent progression of arthritis. Because once you get here, that's it. You need to replace your knee, and there's about an 80% success rate for knee replacements. So there's a 20% chance you're not happy with your knee replacement. And all of these things that I just mentioned are things you can do before you get a knee replacement. Once you replace your knee, no more injections go in there. It's too risky. Bacteria love metal, and they're not going to be able to get rid of it if there is an infection in the knee and it's chaotic. So once you replace your knee, your options for treatment are very, very, very little. And it's a nightmare if that knee doesn't cooperate or gets loose or breaks or something like that. For the most part, they do really well, but they're not perfect. So ideally, you prevent ever needing one or buying yourself 10, 15, 20 years. That's part of what I strive to do, and I hope you get some information about that today. I'm going to plan on doing more of these lectures. This is the first of many. If you have any comments, thoughts, or suggestions, I would love to hear them. You can put them in the description below. And if you have any imaging or you want a consultation, whether in person, either Miami or our Knoxville office, or you can also schedule a Zoom call, a telemedicine conference that we can happily coordinate. You send us the imaging, we review it, and then we get together on the computer and talk about what the different possibilities are. Thank you for tuning in. I hope you learned something. We'll see you soon. Take care.